All right. So, Catherine, do you introduce me or do I start?
Yeah, no, I
Sorry.
can just introduce you. This is good evening, everyone. Thanks for joining the NATF online support group. So, we are joined this evening by Dr. John Groarke, who is a cardiovascular medicine specialist at Brigham and Women's Hospital, as well as a cardio oncologist at Dana-Farber Cancer Institute and an instructor of medicine at Harvard Medical School. And we are really fortunate to have him with us tonight to talk about the important topic of VTE and cancer, which I'm sure many of you, are aware that there is a connection. So we're thankful for Dr. Gork joining us tonight to talk to us more about that. Just a reminder, if you have a question, the best way to ask it is to put it in the chat function, which is the very last option on your toolbar for GoToWebinar. Down at the bottom, it says chat. If you just send it to me, I'll make sure that your question gets asked. And without further ado, I will hand it over to Dr. Groarke.
Thank you, Catherine. I am delighted to have the opportunity to speak with you all this evening about clotting in patients with cancer. So just to give you all a brief introduction to what is cardio-oncology. Cardio-oncology is a relatively new subspecialty within cardiology that has emerged over recent years, and the focus is trying to improve the cardiovascular health of patients who are either actively undergoing cancer treatment or patients who have previously been treated for cancer and are now survivors. We have recognized that oncology patients have a very specific need for cardiovascular surveillance and are vulnerable to cardiovascular disease in a way that is distinct from patients who do not have cancer. And so with that, the subspecialty of cardio-oncology was born, and you will be seeing programs, cardio-oncology programs popping up around the world over the next coming years. So to get started on this presentation, these are my disclosures. I'll kick off with some cancer statistics. Firstly, cancer is on the rise. Approximately 2 in every 5 people will be diagnosed with cancer at some point during their lifetime. And this graph illustrates the projected cases of all invasive cancers in the United States by age and sex. The total projected cancer incidence will increase by approximately 45%, from about 1.6 million back in 2010 to 2.3 million by 2030. And this increase is driven predominantly by cancer who have been diagnosed in patients over the age of 65. Oncologists and radiation oncologists have become very good at their job, and improvements in cancer screening with early detection and treatment are resulting in increased numbers of patients being cured of their disease. And in addition, patients with active malignancy are surviving for longer. So much so that the 5-year survival for all cancer sites has improved from 49% back in 1980 to 69% in 2007, and the 5-year survival continues to improve. In fact, it's estimated that there are over 16 million cancer survivors living in the US alone today, and this number is projected to increase in the coming years. This pie chart shows the breakdown of cancer sites across those 16 million survivors. So you can see that about half of all cancer survivors are from breast, prostate, and colorectal cancers. So these data are from 2013, so the proportions have not changed, but now we have over 3 million female breast cancer survivors in the United States and over 3 million prostate cancer survivors in the US today as well. This pie chart illustrates the age range of cancer survivors in the United States. So only about 10% of cancer survivors are under the age of 50. So how big of a problem is venous thromboembolism in patients with cancer? And many of you will have attended talks like this before, so you're well familiar with the term venous thromboembolism. You will see the abbreviation VTE on slides that are coming, but just for any of you who are new, to remind you that venous thromboembolism is an umbrella diagnosis that includes both deep venous thrombosis and pulmonary emboli, so clots in the legs and arms, and also clots in the lungs. So let me start by speaking a little bit about the incidence. About 20% of all cases of VTE occur in patients with cancer. So if you take all patients presenting with venous thromboembolic disease to a hospital over the course of a year, about a fifth of those will have cancer as well. The annual incidence of clots is 0.5% in patients with cancers versus 0.1% in the general population. So probably about 5 times as frequent in patients with cancer than in the non-cancer general population. And of all patients with cancer, about 10 to 15% will be diagnosed with symptomatic VTE at some point during their cancer journey. And about 50% will have evidence of a VTE identified incidentally at autopsy. So there must be a lot of subclinical disease out there. There is a 7-fold risk of developing VTE while receiving chemotherapy compared to patients who do not have cancer. And there's a 3-fold higher risk for recurrent VTE than patients who had initial VTE diagnosed in the absence of malignancy. So by that I mean that there's a 20% recurrence rate at 1 year in patients with cancer who develop a VTE versus 7% in patients who do not have cancer when they're diagnosed with VTE. And the incidence of venous thromboembolic disease is particularly high in patients who have advanced or metastatic cancer. It's important to note that cancer can actually be the presenting symptom, clot can be the presenting symptom for cancer. Of patients who present with a clot, about 10% of these patients will be diagnosed with cancer within 2 years. So as doctors, when we have a patient presenting with a clot for the first time, we are always very careful to kind of consider whether or not there might be a malignancy underlying the presentation. So why is venous thromboembolism such a problem for patients with cancers? Well, there are a lot of risk factors in cancer patients for venous thromboembolic disease. Firstly, the type of cancer and the location of cancer will influence the risk of a cancer patient developing a clot. We will see in some coming slides that the risk of clots is associated with certain types of cancer, especially. The location of the cancer can be very important. So, for example, kidney cancers, renal cell carcinomas invade the inferior vena cava, which is that large vein that drains into the liver in about 5 to 9% of patients who've got kidney cancer. And so by invading the vein, there's a high risk of clotting off that vein. Also, patients who've got lymphomas often have bulky lymph nodes that can compress veins, and a clot can form in that compressed vein. Similarly, women with uterine cancers or ovarian cancers, those tumors can grow to the point where they start to compress pelvic veins, and clots can form in the pelvic veins as a consequence. The time from diagnosis also influences the risk of clotting in patients with cancers. The risk is highest during that first year after a cancer diagnosis. We will see that certain cancer therapies are particularly associated with an increased risk of clots. Many cancer patients will have central venous catheters, also called ports, for venous access, so to facilitate chemotherapy delivery and frequent phlebotomy. And these catheters can be associated with clots forming around the catheter. Of course, like any patient, comorbidities such as advanced age or heart failure or stroke can influence the risk of clotting in patients with cancer. And then patients with cancer are obviously very vulnerable to recurrent or frequent hospitalizations, and being hospitalized is a well-known risk factor for clot formation. It's thought as well that tumor cells can express procoagulant activity that induces thrombin generation, and also that the patient's normal tissue can also express procoagulant activity in response to the tumor that's present in the body. So all of these can lead to a higher risk of clot formation. So as I mentioned, certain cancer types are particularly associated with a higher risk of clotting. So ovarian cancer, brain cancer, particularly pancreatic cancer. So depending on the study you read, up to 36% of patients who have pancreatic cancer will develop a clot at some point during their cancer journey. And this risk is thought to be 50 times higher than the general population. Lymphoma, I mentioned that bulky lymph nodes associated with lymphoma can compress veins. Liver cancer is also associated with a higher risk of clot formation. Multiple myeloma, particularly certain multiple myeloma treatments, which we will discuss, can increase the risk. And any form of advanced stage cancer, so metastatic cancer in particular, is associated with that higher risk of clot formation. But any cancer, it's important to note, will increase your risk. It's particularly important to recognize that patients with cancer are at a significantly higher risk of clot formation after certain surgeries that are used to manage their cancer. And so I've listed some of the surgeries that are particularly associated with a risk of clot formation in patients with cancer. So esophagectomy would be the surgical removal of the esophagus. So for esophageal cancer, cystectomy, which is removal of the bladder, pancreatectomy, which is removal of the pancreas, gastrectomy, which is removal of the stomach, colectomy, which is removal of the large bowel, lung cancer surgery, and hysterectomy. So these surgeries in particular, which are often used for management of various malignancies, will confer significantly increased risk of clot formation in our patients with cancer. I also mentioned that certain cancer therapies are particularly notorious for increasing the risk of clotting. Immunomodulators such as Thalidomide and Lenalidomide are being used increasingly in hematological malignancies, especially multiple myeloma. And I have a slide that speaks to the risk that is associated with these agents. Tamoxifen is a hormone therapy which is used in the management of breast cancer, which has been shown to increase risk of DVT and PE in women been treated with breast cancer. Bevacizumab is a monoclonal antibody that is directed against the vascular endothelial growth factor receptor. And so this is treatment that is used often in colon cancer, and it is associated with increased risk of clot formation. You can see on this table, in fact, about 12% of patients who are treated with this agent will experience venous thromboembolic disease. These are kind of first cousins of that particular drug, also associated with a slightly lower but still increased risk of clot formation. So knowing whether the particular cancer drug that a patient has been treated with is known to be one of the key offenders is important as we manage patients through their cancer treatment. So here is the slide that depicts the incidence of thromboembolic complications associated with thalidomide and lenalidomide, frequently used in the management of multiple myeloma. And it's important because often patients will be treated with these agents for quite some time, often years, for maintenance management. For maintenance management of their myeloma. And the risk of thrombotic complications is particularly elevated when these drugs are combined with the steroid dexamethasone. So when thalidomide is combined with dexamethasone, the risk of venous thromboembolic disease can be as high as 34% according to some studies, and about 11% for lenalidomide and dexamethasone. So this is often the category of patients where we start to think, well, maybe we should be trying to counter that risk by using some prevention strategies, and we will discuss those. So what's the significance of a clot in patients with cancer? Is it more significant than when you have clotting in patients without cancer? Well, the thing is that clotting is associated with increased morbidity and mortality in patients with cancer. So, for example, if we take patients with pancreatic cancer, patients with pancreatic cancer who develop a clot are a twofold increased risk of death during follow-up compared to patients with pancreatic cancer who remain free of clots. And so why is this the case? Well, we think that the development of clots in patients with cancer may reflect the presence of a biologically more aggressive cancer and hence worse prognosis. So that may be one of the reasons why cancer outcomes tend to be worse in patients who develop clots. So prevention is key. And there are a number of ways that we can reduce risk of clot formation in patients with cancer. We can use mechanical approaches such as compression stockings that you're all familiar with, intermittent pneumatic compression when patients are hospitalized. And then there's also drug prophylaxis. So several classes of agents are used to try and prevent DVT or PE in patients been treated for cancer. These include subcutaneous injections of low molecular weight heparin like enoxaparin, intravenous unfractionated heparin, although intravenous is there for drug prophylaxis, that really should be subcutaneous use of unfractionated heparin, not intravenous. I apologize about that typo. And then we will see that novel oral anticoagulants, so the newer pill forms of blood thinners, are increasingly being investigated and used for DVT and PE prevention in patients with cancer. Now, it is especially important to consider prevention when patients with cancer are hospitalized with an acute medical illness or when they're undergoing surgery, because this is really the key risk times for these patients. But overall, whether or not to use drug prophylaxis in a patient with cancer is decided on a case-by-case basis. And in order to help us with this decision on who should get prophylaxis, several scores for predicting the risk of clot formation in outpatients with cancer have been developed. And this is one such score. It's called the Khorana score. Basically, it takes these patient characteristics into account and applies a score for each of these characteristics when present. So, as I've previously mentioned, there are certain cancers like pancreatic cancer that's associated with very high risk, so that will give you a score of 2. Other cancers are not as high risk, but higher than, say, the likes of breast cancer. This would be like lung or bladder cancer. That will get a score of 1. If your pre-chemotherapy platelet count is 350 or higher, that will give you a score of 1. A hemoglobin of less than 10, or use of red cell growth factors, so these are like the erythropoietins, EPO injections, that will give you a score of 1. A pre-chemotherapy leukocyte count higher than 11 will give you a score of 1, and then a BMI of greater than 35, so class 2 obesity will give you a score of 1. So how this score works is you sum up the individual scores to get a total score, If the total score for a patient is 0, the risk is considered low for developing clot, with a risk of 0.3 to 0.8%. If the score is 3 or higher, then this is considered a high-risk patient, and they have up to a 7% risk of symptomatic clots in follow-up. And then we have the intermediate score, where it's 1.8 to 2%. So there's a feeling that perhaps patients with cancer who have a score in the intermediate or high risk category should be considered prophylaxis. And indeed, several large trials have now been performed using this score to see whether or not there is a benefit to prophylaxis. And I'll discuss a couple of these trials now. So this is a trial called the AVERT trial. It was published in the New England Journal of Medicine just in February of this year. So what the investigators did was to take 574 patients with cancer who had either an intermediate or high-risk Khorana score, and they were starting on chemotherapy. So these patients were randomized to either receive apixaban, which is a pill, 2.5 milligrams twice daily, or placebo for 180 days. And what the investigators found was that the risk of clots was 4.2% in the apixaban group versus 10% in the placebo group. So there was a 60% reduction in risk of clots associated with using apixaban for prevention of clots. And not surprisingly, apixaban was associated with a higher risk of major bleeding, 3.5% in the apixaban group versus 1.8% in the placebo group. Fortunately, there were no fatal bleeds in this study. So the authors concluded that apixaban therapy resulted in a significantly lower rate of venous thromboembolism than did placebo among intermediate to high-risk ambulatory patients with cancer who were starting chemotherapy, and that the rate of major bleeding episodes was higher with apixaban than with placebo. Another trial published in the same journal on the same day is the Cassini trial. So these investigators took 841 patients with cancer. Again, these patients had a Khorana score of greater than or equal to 2, which indicated intermediate to high risk of DVT or PE. They also were starting on chemotherapy, and these patients were randomized to receive either rivaroxaban, 10 milligrams once daily, or placebo. So clots occurred in 2.6% of the rivaroxaban group and 6.4% of the placebo group during the intervention period. And by intervention period, I mean during that period when they were actually taking the pill, either rivaroxaban or placebo. And so again, a 60% reduction in clot formation. And in this study, there was a non-statistically significant increase in major bleeding, 2% in the rivaroxaban group and 1% in the placebo group. So will these trials change clinical practice such that we will start using these drugs to try and prevent clot formation in patients who we think are at intermediate or high risk of developing clots during their cancer care? Well, these trials have been criticized for the fact that some of the more common cancers, like I showed you in the slides at the start, the colorectal, breast and prostate cancer, were underrepresented in these trials. The score was criticized because it doesn't take cancer therapies into account. So, for example, you could have a multiple myeloma patient who calculates to have a score of 0, but if they're taking thalidomide, then certainly they're not at low risk of developing a clot. And it's also important to know that the risk of clot formation for any one patient changes over time. So it's important to reassess the risk frequently. So for example, if I see a patient today who has cancer, I may determine that based on their parameters today that they're at low risk of clot formation and therefore do not warrant prevention treatment. But if I see them in 3 months' time and things have changed, they're more mobile, or they're going for colectomy, or their platelets are very high, etc., well, then their risk is different, and I would need to reconsider whether or not the decision 3 months ago is still valid. It is important to recognize that anticoagulation can be very challenging in patients with cancer, much more so than the challenges we face in patients without cancer. And why is this? Well, patients with cancer inherently are at increased risk of bleeding. So on anticoagulation, there's a higher incidence of major bleeding among patients with cancer. So 6.5 to 18% of patients will have a major bleed potentially while on anticoagulation. As you saw in those studies that I mentioned, 6% seems to be a more reasonable estimate based on the more recent clinical studies. And certain tumors are particularly associated with a risk of bleeding. So, for example, gastrointestinal tumors are associated with a higher risk of gastrointestinal bleeding when a patient is on anticoagulation, not surprisingly. Similarly, if you have a gynae malignancy or a urological cancer like bladder cancer, well, then those patients are going to be at higher risk of genitourinary bleeding, so blood in the urine or vaginal bleeding when being treated with anticoagulation. Patients with brain tumors or metastases, we're always concerned putting those patients on anticoagulation due to a concern for bleeding into the brain. Patients with cancer are often more frail, and frailty can increase the risk associated with anticoagulation. There is often a lot of medications involved, which can lead to interactions. So, for example, ibrutinib is a drug that we use to treat CLL. Ibrutinib can impair the function of platelets, so by itself can increase the risk of bleeding. And then when you put an anticoagulant on top of that, you can have a synergistic increase in the risk of bleeding that we see. There's a significant pill burden that our patients with cancer experience. They're taking multiple pills a day, and now if you're asking them to take a pill to try and prevent the risk of clotting, that is additional medications. And that can come with additional cost, which is often a concern for patients with cancer who are already paying a lot of co-pays. Also, patients with cancer frequently require procedures like line placements or biopsies, which can mean that we have to interrupt anticoagulations for these procedures. Chemotherapies or hematological malignancies can mean that platelet counts can be unstable, and of course low platelets means increased risk of bleeding, particularly in the context of anticoagulation. And furthermore, it's particularly important to take a patient's prognosis and what the patient's own goals of care are when considering whether to use anticoagulation, either for treatment or for prevention of clots. For example, if you have a patient who's got very advanced disease, who has a very short life expectancy, it's important to determine from the patient what their priorities are, involve them in the decision making. They may decide ultimately that they want symptom control and want to avoid injections with enoxaparin, etc. So having those discussions is very important. It's also important to note that there's often more than just one risk factor for bleeding present in any one cancer patient. So any one cancer patient usually has at least two of these: active malignancy, low platelet count, impaired kidney function, a central venous catheter, older age, or drug interactions. And all of these are factors that increase the risk of bleeding in the face of anticoagulation. And when present, when there are more than one present, then the risk can be synergistic. So, for example, low platelet counts. I spoke that patients with hematological malignancies or patients who are receiving chemotherapy can have a low platelet count that fluctuates. When the platelet count drops to less than 20,000, we often hold anticoagulation. When the platelet count is low but greater than 50,000, we continue anticoagulation. And patients who've got those intermediate platelet counts of between 20 and 50,000, well, we decide on a case-by-case basis. So just an example of the challenge that can be associated with trying to anticoagulate patients who have got cancer. So if we fail to prevent a clot in patients with cancer, how do we treat patients with cancer who've got clots? Well, treatment can be considered in two phases: immediately after the diagnosis, so for that first 5 days, versus anticoagulation after that first 5 days. So immediately after the diagnosis, we generally prefer to use subcutaneous low molecular weight heparin like enoxaparin for the first 5 days. Now, if the kidney function is severely impaired, that may not be safe, and we may prefer to use IV heparin. But after those first 5 days, what drug we use depends on the kidney function, what the risk of bleeding is, what tumor type it is. So, for instance, GI cancers might make us less keen to treat with some of the novel oral anticoagulants due to an increased risk of GI bleeding, and then patient preference, whether or not they want to avoid injections. So we generally prefer warfarin if there's severely impaired kidney function. The reason why we prefer heparin over Coumadin for patients who have reasonable kidney function dates back to the clot trial, which was published in the New England Journal of Medicine over 15 years ago. So this trial compared 672 patients with cancer who had an acute clot. They were randomly assigned to receive subcutaneous low molecular weight heparin in the form of dalteparin for 5 to 7 days, followed by Coumadin for 6 months, versus staying on dalteparin for the entire 6 months. And the probability of a recurrent clot at 6 months was much higher in the Coumadin group compared to the dalteparin group. So 17% in the Coumadin group versus 9% in the dalteparin group, and yet there was no difference in major bleeding. So that is why there is a preference for low molecular weight heparin over Coumadin for management of acute clots in patients who've got reasonable kidney function. Last year, we had 2 trials that compared novel oral anticoagulants to low molecular weight heparin in cancer patients. The first of these is here. It was a randomized trial of 1,050 patients who had clot diagnosed in the context of cancer. They were randomized to receive either dalteparin for a full 12 months or dalteparin for 5 days, followed by edoxaban, which is an oral anticoagulant for 12 months. Now, when you looked at both the recurrent clot rate and major bleeding rate together, there was no difference between the 2 arms of this study. But actually then when you look at them individually, there was a non-significant reduction in the rate of clot recurrence with edoxaban compared to dalteparin. 7.9% versus 11.3%, so not statistically significant, and there was a higher rate of major bleeding with edoxaban compared to dalteparin. And most of these bleeding events occurred in the patients with upper GI cancer, which is why I said in a prior slide that perhaps with GI malignancies you want to try and avoid some of these novel oral anticoagulant drugs. So there was no difference in death between the 2 arms in the study. Now, similarly, published last year, the SELECT-D study was a randomized trial of 406 patients who had a clot diagnosed in the setting of cancer. They were randomized to either rivaroxaban for 6 months versus dalteparin for 6 months. And there was a reduction in clot recurrence with rivaroxaban compared to dalteparin, so 4% versus 11%, and a similar rate of major bleeding, about 6% versus 4%. But again, with rivaroxaban, like with edoxaban, there was an excess of non-major bleeds in patients with upper GI cancer predominantly. And there are 2 other trials ongoing that will compare apixaban to dalteparin, and then low molecular weight heparin with or without Coumadin to either apixaban, rivaroxaban, or edoxaban in the Canvas study. So we wait for the results of those studies to come out. It's very important to recognize the higher risk of recurrence of clots in patients with cancer compared to patients who do not have cancer. So there's a 3-fold higher risk of recurrent clotting than in patients who do not have malignancy. So a 21% recurrence rate at 1 year in patients with cancer versus a 7% in patients without cancer. And if you do have a recurrent clot in the context of cancer, it is associated with a poor prognosis. And it's because of this risk of recurrence that we often elect to extend the duration of anticoagulation in patients who present with a clot and have a cancer diagnosis beyond the usual 3 to 6 months that we might use in the non-cancer population. So again, we have some scores that are there to help us predict what is the risk of recurrence, and these scores can inform whether or not we decide to keep a patient on anticoagulation beyond those 3 to 6 months. So certain factors like sex, type of cancer, early stage is good, advanced stage is bad. And again, the total score allows us to calculate a probability of recurrent venous thromboembolic disease. Other risk factors in patients with cancer that is associated with recurrence, as I said, metastatic disease, short interval between clot diagnosis and cancer diagnosis, so if it's less than 3 months. And then if the patient is due to continue on cancer therapies that have a procoagulant risk, so like the Thalidomide example that I gave earlier in the talk, if a patient presents with a PE rather than an extremity DVT, and if the clot burden is particularly high at the time of presentation, well, that can predict a higher risk of recurrence. So some tips that I have for patients with cancer to try and reduce their risk of VTE. It's important to know your risk, and I think it's important to ask your doctor if the type of cancer you're diagnosed with or what the type of cancer therapies that have been proposed for you are associated with a clotting risk. It's very important to always remind your providers if you have a past history of clots or if there's a family history of clots. Try and keep mobile during treatment as best one can. Wear compression stockings, keep hydrated, and advocate for yourself. So push the conversations. Ask your doctor if you would benefit from using the likes of apixaban or enoxaparin for prophylaxis. If not, ask them for advice on ways that you can reduce your risk. And then, because the risk does change over time, as I explained, revisit these questions regularly. Bring them up at each visit because things can change with time and with blood tests, etc. And then be particularly cautious around the time of surgery or long-haul travel, etc. So the take-home points I would leave you with are that clotting is a common complication of cancer, but fortunately most individuals with cancer do not develop clots. There are known risk factors that one should discuss with their doctor if they have cancer. Prevention is key, and there are a number of ways that we can try and reduce risk of clot formation in patients with cancer. If one does develop a clot in the context of cancer, there are a variety of treatment options available, each of them with their own specific bleeding risk. In patients who've got reasonable kidney function, usually we go with low molecular weight heparins. We have done so for a long time, but I think we're increasingly moving towards the more novel oral anticoagulant drugs with some clinical trials that have come out in recent years. And if there's severe kidney impairment, well, we're still often leaning towards Coumadin. it is particularly important to appreciate the high recurrence rate, and so often we extend the duration of anticoagulation in patients who continue to have active cancer or continue on cancer therapies associated with clotting risk beyond the traditional 3 to 6 month treatment periods that we use in patients without cancer. And with that, I'd like to thank you all for your attention and open it up for questions and answers.
Well, thank you so much, Dr. Groarke. That was a really thorough review, and I really enjoyed your take-home points. So we did get a bunch of questions, so I'd like to start working through those. And I think one of the main theme that is coming through in the questions is, what about after cancer? If you are one of those 16 million people who have previously had cancer, but you're in remission or there's no evidence of disease now, are you still at an increased risk for blood clots as a result of the cancer?
So I think if one has had a diagnosis of a clot at any point, then even in survivorship, there's definitely an increased risk of recurrence compared to the non-cancer survivor cohort. But if one has not had a clot diagnosed during their cancer treatment and they're now survivors, then the risk can still vary. So for instance, in patients who have had radiation therapy or surgery that may have resulted in an anatomical issue with a vein, that can increase the risk of clots. If they're on any maintenance therapy to maintain remission, so that would be particularly with some of the hematological malignancies, that may result in a residual risk. But I think for the majority of patients who, for example, have been treated successfully for a cancer, no longer on any cancer maintenance drugs, and they hadn't a clot during their treatment, then yeah, the risk probably falls back towards the general population.
Okay. So just kind of talking about risk and whether or not you're at a higher risk for blood clots, if you have a predisposition, I guess, for cancer, such as in this particular example, they said the BRCA gene mutation, and they want to know if just having that, because they are at a higher risk for developing certain types of cancer, are they already at a higher risk for blood clots?
So the BRCA mutation would not necessarily would not directly increase the risk of clots, but indirectly it probably increases the risk of clots because it gives you a higher risk of developing certain forms of cancer. So if you get those cancer, if you're at a higher risk of getting those cancers because of the BRCA gene mutation, and if you get those cancers, then you're at higher risk of developing a clot. So lifetime risk for BRCA gene mutations of clot formation is probably higher, but it's indirectly mediated by the actual cancer risk rather than by any direct effects of the BRCA mutation on the clotting pathway.
Okay. Interesting. So, and then kind of the same type of question, but patients that are genetically have a higher predisposition to blood clotting, such as factor V Leiden, if they develop cancer, is their risk for a blood clot even higher?
Yeah, so inherited thrombophilias, so family conditions that increase your risk of clotting would be an added risk factor on top of the cancer diagnosis. So certainly that those patients would be at higher risk of clot formation during cancer therapy, particularly if they have a personal history of clots as well. So certainly that's why I would recommend all patients to bring up their family history of clotting disorders with their doctor, at their initial oncology appointments.
Oh, interesting. Okay. So really prior history of clotting is really important to discuss with your doctor.
Very important. And, particularly for patients who have a lot of diagnoses and their medical records may be extensive, for the busy oncologist, it is important to highlight for them that clot that one may have had 8 years ago, because that is definitely something not to be overlooked by the oncologist and warrants a discussion about what can be done to reduce the risk of clotting during their cancer care.
And how long should that continue after their cancer treatment ends?
How long should preventative therapy like enoxaparin or apixaban continue after cancer therapy ends? Is that the question?
Yeah.
I guess until one is back to their baseline level of mobility, or their blood parameters like platelet count, etc., are back to baseline. So depending on how quickly one recovers, that would influence the duration of prevention. But I would anticipate for the majority of patients, you're talking only a period of several weeks after completion of cancer care.
Okay. There's a couple questions too about radiation and, does it cause blood clots? Is there any connection there? Can you talk about that a little bit?
So there's radiation. It depends on the site, the field of radiation. So radiation oncologists have become very sophisticated in targeting radiation to the cancer, to the tumor only, and trying to reduce the scatter of any radiation to normal organs or vessels that may be surrounding the tumor. But certainly where there are superficial vessels, so like veins in the neck, or arteries in the neck, or veins in the femoral area, or arteries in the femoral area, if they're in the field of radiation for, say, like head and neck tumors, or for like pelvic tumors, then radiation can cause damage to these blood vessels, and the injury to the blood vessel wall then can result in venous thrombosis or arterial thrombosis. And I should say that even for the coronary arteries, this is not veins, obviously, but we see an increased risk of coronary thrombosis, the condition that can result in heart attacks from in patients who have high doses of radiation to the chest that can cause injury to the coronary arteries.
So it's damage to the veins and the arteries from the radiation that are causing the clots, not the actual radiation itself.
Exactly. And I should emphasize that for the majority of people who receive radiation therapy today, in the modern era, with CT planning and very sophisticated radiation oncology techniques, this risk is getting less and less each year.
Great. And should patients who have cancer and a history of blood clots, should they ever consider having filters placed due to their high risk?
So that is something that is decided on a case-by-case basis. Filters are sometimes used in the oncology population where there may be some contraindication to some reason why we can't use blood thinners. So significant bleeding, or blood parameters that are precluding use of anticoagulants. So that question is very much decided on a case-specific basis, and would involve a discussion between the oncologist, the cardiologist, and or the vascular interventional doctor. I would say that in my experience, the most time that I spent discussing cases have been around the use of filters. So there's definitely no straight forward answer to that question. It's a case-by-case basis.
Okay, so it's definitely something that requires a longer discussion.
Exactly, yeah.
Okay. Okay, so that was the questions we got. One thing I always like to ask our presenters at the end is, obviously both cancer and VTE are difficult diagnoses and illnesses to go through. So any, words of advice for the patients that might be going through that now or their caregivers?
I think the only words of advice I have is that cancer care can be a very busy time for patients and their providers. And so the prevention and discussion around risk of clots and prevention of clots can sometimes get overlooked. So I would encourage patients and their caregivers to be their own advocates with their doctors and, prompt the conversations, because very often there's just so much to discuss during those clinic visits with their oncologist that really the first time a clot is considered is when a patient presents with symptoms of a clot, and at that point it's too late to prevent it. So just to bear it in mind and raise it as a concern and a question at your visits.
All right. Wonderful. Well, thank you so much, Dr. Groarke. That was great. And thank you for taking the time to answer all the questions at the end. We really appreciate it.
No problem. I enjoyed it a lot.
Wonderful. And thanks to all the attendees for joining us this evening. This presentation will be posted on NATF's website, so if you want to refer back to it, you can find it there under the Patients tab and then Support Groups. And I hope you will join us for our next online support group, which will be on June 18th with Dr. Margaret Fang from UC San Francisco, who will be giving an update on the reversal agents for anticoagulants in the event of a bleed. So thank you so much, everyone, and have a great evening.
Thank you, Catherine, and I hope everybody has a good evening. Bye-bye.
Thank you. Bye-bye.